Thank you, thank you for your kind invitation. I, we would like to thank also all the members of the GAO committee because you did a great work. So thank you for this beautiful consensus. And me and Marco will talk now about some challenging conditions. So we will present some cases that are borderline, you know, they are not a conventional situation. You are really familiar, I think, with the CMI concept, and now you are also familiar with the CMI fixation, and you are familiar with the different situation of bone density and the different CMI fixation that you can obtain. But unfortunately, we have to deal with some more complex situations. For example, situation where only C fixation is achieved, situation where we are able to obtain only MI fixation, and last but not least, situation where we can reach only I fixation. So it will be very difficult to manage those kind of situations. And we must remember that for the anytime loading, the most important factor, the key factor for the fixation when you make an immediate loading or an anytime loading is the crestal part of the bone, so the C fixation. Because if you have a very long span under lateral forces, it will be easier to have a failure. And as we said today, we do not want failure. So how can we manage those very complex situations? How can we manage the anytime loading in those situations? And I would like to say that for us, for me and Marco, anytime loading means immediate function. We are talking about a single implant, and all the patients that came in our office wants to came with one tooth and wants to replace immediately the tooth. So they wanted to go out with a new one, provisional one, but a new one. So what we are trying to do in our everyday practice, also in those complex situations, is an immediate function. An immediate function is different from immediate loading because we are talking about a single implant, not obviously multiple implants. So it's only a prosthetic function, an aesthetic function. In fact, we ask the patient not to chew on the implant for at least a couple or 3 months. So it's very important to understand this fact, because if you have to manage with a particular situation, you must suggest the patient to be very, very precise and to have a great attention during the chewing phase. So now we will wake up with some clinical case, because our lecture is based essentially on a clinical case. So let's go on with the C fixation.
So the first clinical case. I'm sorry, I don't see the computer. I don't see there. I look at here because I have problem with my contact lens. So the C fixation. This is a lady. She has a left canine, upper canine, in a wrong position. She doesn't want to underwent orthodontic therapy. I have tried in every way to convince her, please do ortho, do ortho, do ortho, and she doesn't want to undergo on ortho. So we extract the tooth, me. I place a temporary Maryland, and I wait for 3 months. 3 months, you can see the essence in the soft tissue. So I know that an immediate provisional restoration in this situation is a little bit facing for me. So I decide to place the implant. The stability was not so good, so I decided to submerge the implant, to use a non-resorbable membrane to regenerate the root prominence to give her a better aesthetic. So this is the membrane, the Maryland, the modified Maryland to don't touch the soft tissue, the implant. 6 months later, at the reopening, the new bone formation, a soft tissue graft is connective tissue, a healing screw, and 1 month later, I proceed with the provisional restoration. The provisional, when I do this with the connective tissue graft with new bone, I use a concave transmucosal puff, as you can see here. I modify this provisional restoration, adding some resin, as you see. You can see the new resin. To do what? To press the tissue in the position that I want. So I modify the provisional restoration many times until I reach what I want. What I want is a result like this, or better, like this. I would like that the tooth appear as natural as possible. I don't want that the patient will be able to recognize the implant restoration from a natural tooth. And to do this, I decided to do a delayed loading in this kind of patient. Another case of fixation. A molar has to be extracted for decay problem. I have a good septum, as you see, 4.5 millimeters, but it's not enough to keep an implant. So I have to do a sinus elevation, and I don't have a very nice fixation. But I want to do an immediate to give an immediate restoration to the patient. So I stay very careful during the extraction. I keep intact all the bone, a very nice septum. I place a 4 millimeters diameter implant, some bone substitute up to the free gingival margin. I reline a provisional restoration. In this case, I use immediate provisional restoration. And as Gluliano has said before, I don't give any function to this restoration. No occlusal contact, neither in static, neither in dynamic occlusion movement. So it's just a provisional restoration to close an hole and to give to the tissue a support to heal in a direction that we want they go. This is the sinus lift, sorry. The pointer is the problem. The sinus lift, the temporary abutment. The temporary restoration is not visible because its resin is transparent, and the cut of the CBCT showing all the work. 1 year later, everything is going well, and 5 years later, everything is still going well, fortunately, I say. So it's possible to do everything with this kind of implant because we have good stability, we have good components, and we are able to manage them in the right way. In the literature, we will find that it's impossible to have a nice papilla between two implants, and it's not completely true, I believe, because if you don't manage the implant and the tissue in the correct way, you will never have a nice papilla, but if you are able to manage them, you can reach good result. This lady came to my office telling me the two premolar are moving. Are you sure? Yes, she was right. So I extracted the teeth. I insert 2 implants, 2 temporary abutment, and I reline 2 provisional restoration connected between them. 6 months later, and these are the soft tissue. The soft tissue are very natural, in my opinion. The papilla between the two implants, it is a true papilla, like the papilla between two teeth. The shape is an ovate shape, it's not a rounded shape as the healing screw that we use usually. As you can see, the prominence of the root is maintained. On the molar, there are two old implants. They were precedent to me. And you can see the difference. I have maintained perfectly the root bump. Here, there is no bone wall. So they are not natural. 5 years later, with a definitive restoration, they are very, very natural. Nobody can see that they are crown on implant. They are normal crown or on normal teeth, I believe. And this is a result and a biggest in magnification. Another case, a molar root fracture. I have to remove, to extract it. I have MI fixation in this case. I extract the tooth. I must maintain intact the septum because without it I don't have anything in which to place the implant. I place the implant into the septum. I put some bone substitute up to the free gingival margin as usual. During the extraction, I lacerate a little bit the soft tissue. I give one, two suture. 10 days later, and this is the result at 6 months. With the provisional restoration, I have well maintained all the profile of the soft tissue. Here is some bone substitute that doesn't give any reaction, is well tolerated, is well integrated. And after 3 years, the tooth is almost like a real tooth. Here, there is no any dehiscence, so the patient can chew whatever she wants without the risk to impact the food beside the tooth. And the result is very pleasant.
This is another case that is similar to the one that you have already seen, MI fixation. And here, Richard, you can see that I use, same as you, spatial burr, high speed. To center the septum because it's easier. And we insert an implant. In this case, we decided not to put a provisional restoration, but we decided to insert an healing screw, the biggest that we have. And you can see that we reach a good conditioning of the soft tissue, but the shape is completely different from the shape that you have seen before with a provisional restoration. So the presence of a provisional restoration, as Marco said, is not only important from an aesthetic point of view, because we are in a molar area here, so in inferior part of the mandible, so it's not so important, but can condition in a better way the soft tissue. In fact, the final result is quite a good result, but you can see that the tooth is a little bit smaller, that we have a little bit resorption in the buccal part, comparing with the case where we insert the immediate restoration. So, as I told you before, whenever we can, we try to insert the immediate restoration, not only for aesthetic reason, but also for conditioning the soft and hard tissue. This is another case with only MI fixation with a vestibular bone defect. And here you can see the implant in the first upper premolar just inserted. This could be an interesting case, an ideal case also for immediate function with a provisional, but the problem was that the patient has no molar. So it will be very difficult for me to ask to this patient not to chewing in this area because she is not able to use the molar. So we decided to perform a conventional loading in this case, although it was possible to do a regenerative procedure and to insert an immediate provisional for aesthetic reason and for conditioning reason. This is another case, MI fixation. We are in a central incisor, the first upper left central incisor with a fracture. You can see the fracture on the X-ray. And obviously in this area is very important for the patient to have an immediate restoration, an immediate fixed restoration without any contact in occlusion and during the excursion phase. So we plan to extract the tooth. We use, in this case, to be very precise, the navigation system of the Neobiotech company. So the NaviGuide, you can see here that we extract the tooth and we insert the implant using the navigation system. And at the end of the surgery, we were obliged to insert a very thin bone layer to recreate the vestibular part of the bone, because the fracture has damaged the vestibular part, and we insert some heterologous bone just around the implant. An healing screw. The healing screw was inserted because we need to check which is the stability of the implant, and now 2024 we have for example the AnyCheck, which works very, very well in this situation. We had 82 EST values, so the case is a case that can be performed with an immediate provisionalization, and you can see here the provisional restoration. We wait at least 6 months, and we add some resin because we would like to have an higher parabola, which is similar to the contralateral incisor, and after 1 year we perform the final restoration, and we had a good soft tissue healing. Now another challenging situation when you have only apical fixation. For example, when you have to extract the canine. The canine are very big tooth, and you have a special shade of the canine, so the contact between the implant, otherwise you use a 4.5 or although I use a 4.5 implant, the contact between implant and the bone is only in the apical region. So we have to go deeply into the mandible, and we have to insert the 2 implant, to insert also heterologous bone all around the residual portion of the dental alveolus. And once again we check the situation here just to show you the X-ray position of the implant. We check once again with AnyCheck, and in this case, because is a case with 2 implant and a bridge of a 6 element, I prefer to take an impression, to send the impression to the lab. This is still an analogic case, is an old case, but you can have in 24 maximum 48 hour the fixed provisional restoration. And you can see on the left canine that there was a sort of dehiscence, and so I accentuate the concavity of emergency profile, and in fact after 6 months we had a completely healing of a soft tissue around also the left canine, and we were ready for the final screwed restoration after 1 year. And here you can see the final X-ray. Tomorrow I will speak about the managing of the sinus elevation and anytime loading in this area, and I will present once again this case. In this case we had a root fracture. We had a very small contact in the crestal part, only in the palatal part. We had a very small contact between the bone and the implant in the middle part, so we had a very good apical fixation into the inferior cortical part of the sinus, and tomorrow I will explain to you how it's possible to reach this apical fixation. So the provisional, in this case I needed to raise a flap because there was the needing for a big regeneration, and after 6 months on the left, the provisional restoration, on the right, the final restoration 1 year later.
Going on with eye fixation, this is a very recent case. I don't have the final restoration. I have inserted is a lateral, right lateral. I have inserted the implant, and you can see there is a fracture in the C portion. There is a fenestration in the ham portion of the implant, so the stabilization is only in the high position. I decided to do an immediate provisionalization in any case, because I like to do provisional restoration. But I was doubting to do or not to do. So the help that any check can give to us is very important, because I trust in my hands, and probably I am a little bit presumptuous. But I don't take care about the numbers sometimes. I just feel the sensation with the finger. But the numbers are important when you are not able to decide. In this case, I had a lot of doubt. So I used the AnyCheck, and the AnyCheck told me 82 IST. Incredible. I don't have C fixation. I don't have ham. I is incredible. The implant is 13 millimeters. It's not so long. So I decided to place a restoration. An immediate regeneration, some bone collected from the bar, some bone collected from the box, a collagen membrane, the restoration, always concave in immediate load, and this is the restoration immediately placed. As Giuliano has already told, is provisional, not functioning. And the patient was very, very happy. Another case, a little fenestration, but very long. So I decided to correct it with a... Dimmi griglia, che mi sfugge griglia.
With a titanium mesh.
With a titanium mesh. I was forgetting mesh, sorry. With a titanium mesh. And with a titanium mesh, I don't have feeling enough to do immediate provisionalization. So in this case, I submerge it, and I wait until 6 months to reopen the implant and to give her the final restoration. All these cases are, if we want, at the limit. So how to decide to place a kneeling screw, to do an immediate provisionalization, or to submerge the implant? First of all, there is our philosophy. Every time we can, me and Giuliano, we do immediate provisionalization. I don't like to stay with the nail in my mouth, so I try to give immediate to the patient. When I cannot, because I don't have stability enough, I can place a kneeling screw. And if I don't have absolutely stability enough, I submerge the implant. The only tool that I have, I don't have the drilling machine that Dr. Ho had, so I'm not able to understand. I use high-speed drilling, so I don't feel the different pressure. So the only tool that I have is my finger and the AnyCheck. And with these two tools, we try to understand, to solve all our cases. And with this, we are finished our lecture. Thank you.
Thank you. Beautiful, beautiful cases like always.
Thank you.
Thank you.
Always fantastic cases.
Thank you.
Italian guy.
You are very kind.
Apart our faces.
Marco and Giuliano, I have a couple of questions for both of you. First of all, Marco, would you review with us just a little bit? We've talked some about the CMI loading of our implants with a normal, healthy bone. What you guys have described is what we typically see on a daily basis of difficulty. But would you just review with us a little bit of when do you decide to load versus not load, or provisionalize and not provisionalize your implants?
Yeah. With a single implant, we never load because we want to fly in a safety condition. We don't like risk. The patient pay us to have a result, not to have a research.
Mm-hmm.
So it's always provisional, never loading for the single. And neither in static, neither in dynamic occlusion movement. So this is the first answer. And when I decide to place a provisional restoration or not to place, every time I can, I place the restoration. It happened also that during screwing the restoration, I moved the implant. So the stability was not so strong. I removed the implant in the right position and I left there the provisional restoration because the stability was enough. The rotating is another thing. Mm-hmm. The stability movement up and down or in lateral movement, I need the stability. But as I told you before, I don't check the stability with other device than any check. So I don't look at the torque controller. I just look at if he is stable. If it is stable, I every time use immediate provisionalization.
Patients in Italy must obey or listen to what you say. When you say don't chew on it and leave it alone, they must listen, right?
Yes.
In America, they don't, but
No,
They don't.
no, they chew on it. Giuliano, thank you. Giuliano, would you review with us a little bit about, with some of these cases that you're having with immediate extractions and things, what are some of the AnyCheck values that you're seeing with this type of a situation that you've described versus a traditional setting where you would have CMI complete fixation for that?
Thank you, Jeffrey. We must think about the fact that me and Marco started with this kind of protocol around 2000. We were very influenced by the article of Canole e Lozada. I don't know if any one of you has already read this publication. It was about the single implant in the anterior area with post-extraction implant and immediate function. So we started 24 years ago, and at that time we had no tools to understand which stability we are able to reach. Only we can measure only the Newton centimeter, and we know that sometimes if we have a value of 40 Newton centimeter is not enough to be sure that our implant will be of success. So we had the time to understand by our handling, our feeling, which is the situation. Obviously, as I showed you before, for example, if we don't have a perfect occlusion, we have missing teeth, we are in doubt to do or not to do immediate loading. But this is something rare normally for our patients. So now we have AnyCheck, and we trust a lot in AnyCheck. Tomorrow we will talk about the use of AnyCheck in managing the sinus elevation with immediate loading. And normally if we have a value of more than 70, we can go on with our work. But sometime me and Marco speaking together, we said, oh, in that case I didn't have 70, I have 65, but I do the same, the immediate provisionalization. So I don't have a real answer to your question. It is related to the experience for this challenging case.
Sure. Awesome. Great cases.
And
Yes.
Marco and Garlini, I like your way of placing implant and the way of choosing the diameter of implant. You choose a little bit narrow implant in the posterior and also anterior too. But some people want to fill all the extraction socket with wide implant, right?
Yes.
But you don't like that.
No.
Okay.
It's a great error.
All right.
When I started my practice, and also Marco, in the end of the 90s, we were using at that period 5.56 millimeter diameter.
6.5.
But yes, but we realized that it's better to stay away from the bone and to have a smaller implant. Obviously, it is better not to use a 3.5, for example, in the molar area, but the 4.0, it will be fine.
But we are from Korea. We're eating very hard, food like
Sticky food.
kimchi and something like that. But the
In Italy is the same.
Italian guy
Food is very
just
important in Italy.
very soft food. So it's totally different. So if we survive in Korea, so it works in everywhere, because we eat hardest things, right?
Right.
And also, I don't think it's a 4 millimeter diameter implant is enough to the posterior first molar. So we recommend at least 4.5. I recommend 5 millimeter diameter implants in the posterior mandible and maxilla and in the molar area.
Especially for Korean people.
Especially for Korean people. But so and also in the anterior, using the 4 millimeter, we just leave the space and to fill the natural bone, right?
Yes.
So I like that things. It's great. And I kind of fancy, you get the fixation in the septum area,
Yes.
in the first molar.
Yes.
So how do you get that?
It's a very thin burr.
Yeah.
We call it ferox because it works very strong and is about 1 millimeter in the point, and then 1.2, yes, 1.2.
It's very similar to the point drill in the master kit.
Yeah.
Yes, it's quite similar to the point drill in the master kit.
Okay,
Question?
that's great. Yep.
Yes. I have two questions for you. In the cases that
For me or for?
No, for you. Ha
For
detto
me,
per te.
for you.
in the cases that you placed the implant in the septum, don't you consider that it's easier to do the perforation first and extract the roots after? This is the first one.
Yes, it's a possibility, but it's not easier for me.
I think that if you extract first, you have more risk of deviation.
It's right.
And you can use osseodensification to expand the septum also. But
Yes.
the second one, you showed a case where you placed a provisional in the posterior area
Yeah.
and then a stock healing abutment. Don't you consider that in a molar, non-aesthetic area is less risky, and you say you don't want to take risks, to place an individualized healing abutment because it maintains the soft tissue profile? And I agree that even in the posterior area, soft tissue profile is important because of food impactation, etc. Do you understand what I'm saying?
Yeah.
Yes.
With a low profile, sealing the socket, but less risky.
Yeah, but it's the same because our provisional restoration are not in contact. You don't have any contact between the teeth. So when you chew, the food doesn't take care about the height of the restoration. Also, if your restoration is flat, if the patient chew on the restoration. So it doesn't change the problem. But in my opinion, it's better a provisional restoration. I have a better design. I decide where to start with the concavity, and I don't place the material inside the socket, but I place the material on the provisional. I can guide in a better way the tissue, in my opinion. But you obtain a almost similar result, but you don't change the risk, in my opinion. What do you think about, Giulio?
Yes, I agree, and especially for the upper molar that you have seen today, we have some patients that when they smile, they show the upper molar. So if we put a real tooth, obviously without any contact, it will be more aesthetic than an individual healing screw. And for the other question, Riccardo, yes, you can do this procedure, as you said before. You can prepare and then extract the tooth. You can use the osteodensification. We do this sometimes. And now we are trying to preserve the vestibular part of the root in the anterior area. The socket shield technique, I think that everybody knows this procedure is very, very common in Italy to do this. There is a society, Italian Society of Socket Shield and so on. But we are a little bit scared about the possibility to have maybe an infection or something like that. And now in Italy we have a lot of legal problem because if the patient has a part of the root in the vestibular region and another dentist who doesn't know this procedure see the patient said, oh, you have this problem because there is a part of the radix, and so this will create a legal problem.
Wow.
So yes,
We have the same problem in America.
I know.
Really?
I know.
So socket shield is stopped in
Yes,
America too.
we are in the second position
Yes.
after America.
Yeah, but to conclude, Giuliano, one of the inventor of the socket shield is from German, from Munich. He has a lawyer inside his office working for
That he's
him.
done socket shield on, right?
Also for this. But to come back to the first molar, Giuliano and me, we give a course, an annual course of implantology, logically, and we say that the most difficult drilling is for the first molar, because the patient doesn't open the mouth completely. We don't see very well what we do. There is the septum, so we suggest to use guided surgery. You extract the tooth and you do guided surgery. This is the only way that we have to be precise with the implant insertion. This is what we do. Every time we can, guided surgery.
Yep.
Sometimes the speedy, the traffic in the office, we forget to do it, but when we remember, guided surgery to be sure.
Yeah, I like the socket shield techniques, especially in the upper anterior regions.
Yeah.
We get good fixation. Even we can get the C fixation too
Yes.
because of that. And the result is very, very successful for long term, right? Everybody agree with that, right? So why not try that, right?
Socket shield technique is evidence-based one, scientifically. But some arise legal problem. You have to remove
Yes.
before implant placement. One tip is before implant drilling, you can cut the crown portion and high speed.
Yes.
Yes, long length drill is make a top-down drilling there, and then remove
Yes.
the residual root. Before cutting the crown, you have to make it give mobility,
Yeah, to the
the ease to remove,
tooth,
and
yes.
then cut and
Yes.
drilling and step-by-step drilling and remove totally and place the implant.
Sometimes
That's
we
the idea.
sometimes we do
Yeah.
we do this procedure.